So we're here for Dr. Tina Montreuil, an associate professor. She's going to talk to us about specificity of changes and importance of maternal well-being during pregnancy and maybe beyond. But before she begins, I want to acknowledge that we live, work, and play and participate in a community on the unceded, ceded, and traditional territories of the 630 First Nations, each of which possess their own unique traditions and history here on this land that we now refer to as Canada. We acknowledge the importance of the Truth and Reconciliation Commission of Canada's call to action and the United Nations Declaration on the Rights of Indigenous Peoples Act. In all of our work, we are committed to ensuring Indigenous women's rights to health and safety and the equal opportunity to participate in a manner that recognizes and respects Indigenous cultures and traditions. Today, I'm joining you from Toronto, which is covered by Toronto Purchase Number 13 with the Mississaugas of the Credit. Toronto is now home to a vast diversity of First Nations, Inuit, and Métis who enrich the city. Many of our members also live in Vancouver, which is part of the unceded traditional and ancestral homelands of the Coast Salish peoples, the Musqueam, Squamish, and Tsleil-Waututh First Nations. And this is brought to you by the Women's Health Research Cluster. We have over 500 members now across over 30 countries. So that's a little outdated. It's outdated almost every day, which is fantastic. It's free to join, so please join and become a member, become a part of our vibrant community. We bring you a number of events like this seminar series, trainee research presentation opportunities, as well as some conferences and workshops. We also have a new grant facilitation officer, and that's available to anyone across the world. So please do email us about that, and we're happy to support. And every once in a while, we have trainee travel awards. So please do apply for those when those come out. And of course, we thank our sponsors. We can't do this without them. And as I said, please consider sponsoring or becoming a member. And so with that, I'm going to stop sharing my screen and introduce Dr. Tina Montreuil. And she's going to tell me how to pronounce her last name. She's an associate professor in the Department of Education and Counselling Psychology and an associate member of Pediatrics and the Psychiatry departments at McGill University, which is in Montreal. She holds a scientist appointment at the Research Institute of the McGill University Health Centre and is a research scientist at the Research Centre of Sainte-Justine Hospital. Dr. Montreuil is a director of Childhood Anxiety and Regulation of Emotions Research Group and the co-PI of the Montreal Antenatal Well-Being Study, a prospective longitudinal birth cohort study. Her research focuses on investigating predictors of intergenerational transmission of mental health and illness. Notably, her research has demonstrated that parent emotion regulation is mediated by parent emotion regulation socializing behaviors to predict child emotional regulation and future psychopathology. And I'm sure she'll be telling us a little bit about this work. And of course, as many of you know, I've known Tina for a while now. It's always a treat to listen to her talk. She has a number of accolades. She is a powerhouse. I don't know where she gets all of her energy from, but I will say that I like to give fun facts. So it's not just about all of the academic achievements that our speakers have. And Dr. Montreuil has a really great fun fact. She's a classically trained singer. Now, she did tell me that she'd only tell me if I didn't make her sing. So I won't make her sing, but I really want to have the opportunity to listen to her sing at some point. And she even competed at the provincial level. So that is pretty amazing. So without further ado, please welcome Dr. Montreuil.
Hello, everyone. Thank you, Lisa, so much for the introduction. It's really a pleasure to be here. And I guess I had also my own land acknowledgement. So because we are in Montreal, we are sitting on the Kanien'kehá:ka territory. So I wish to point that out as well. But really, it's such a pleasure to be here. And I was delighted to receive an invitation when I sort of mentioned that I would be interested in presenting, because I know that the future of Canada's health, women's health, is here. And so for me, it's always a big privilege to be able to have this opportunity to have, not just in my capacity as a professor teaching in my case, future psychologists and clinicians, but also different various individuals in the women's health field or space. So it's really a pleasure to be here. So for those that are here, there's going to be like a little twist because you came because I will be talking about, the specific changes that occur during pregnancy and why I think it is relevant that we address these as part of women's health and women's care. In my case, as Lisa mentioned, with regards to some of the focus of my research, I am a developmental psychologist. So for me, there's always an aspect of women's health that I'm interested in looking at in the perspective of child well-being. But more and more in the past couple of years, and I'll talk a little bit towards the end about some of the work that I'm doing with the Montreal Antenatal Well-Being Study, where we're not only looking at aspects of women's health, but also looking at, the offspring and what happens over time using a longitudinal cohort, prospective cohort sort of study design. Again, more and more, I will say, from going from a focus of interest in women's health on the basis of what it causes or what it leads to or the influences on child, more and more I'm becoming interested in women's health itself, and so the aspect of what happens after pregnancy. And so today it's going to be presenting you with some of the work that I'm doing, but also I figured what better space, and I only got this validation when we connected earlier today, but I felt what better space than to use the intellect, the motivation, the drive of I guess of trainees in this space to really get you to not perhaps just become sensitized to this, the importance of women's health surrounding pregnancy, and it's just an aspect of women's health, right? Like, women's health is not just pregnancy per se or her capacity or to give birth, but I think as I will be presenting today, there's a lot of changes that occur that I think we need to pay closer attention to, and hopefully not just sensitize you, but also get you thinking perhaps like, what could be my involvement? Like, as my career, could I be interested in helping out in sort of paving the way to the future of women's health in Canada and beyond? So that's really what motivated me, or what was driving me today in preparing this talk. So with this long introduction, and to address Lisa's comment about how do we mention Tina's name, it's actually pretty good the way she was pronouncing it. And I often use the Montreal, like Tina Montreuil from Montreal. So it's actually Montreuil, but that's quite difficult to pronounce. So whichever way, if Montreal helps you phonetically pronounce it, it's really good. So the little twist here that I added today, and hopefully you'll be happy with this, and you'll forgive me if ever you don't like the element of surprise, but it was really talking about the specific changes during pregnancy and the importance on maternal well-being, but also what's the aftermath, what happens as a result of pregnancy, and also give you the status of, what's happening, like what's being, done in Canada with regards to women's postpartum health. So I have to say that this reflection, I can't take all of the credit for it. Since I've been working with ENRICH a couple years ago, so some of you might be interested in, if you're working in the area of perinatal, pediatrics, that there's this great incubator, I will say, of young clinician scientists called ENRICH. And as part of ENRICH, I became very sensitized to the importance of working with people with lived experience. And I knew that because I've been working in the mental health sphere for years. And we can keep some of that, those questions with regards to what has been my path to becoming an academic and a clinician. It's quite atypical. So I'll reserve that for questions afterwards. But I think it's encouraging for people that might think that it's very linear. And in my case, it wasn't. And so I think that's what's really encouraging as well, is that, your path may be atypical, but it doesn't mean that you still can't achieve your goal as a trainee and professional. But more and more I've become sensitized, or at least I use that word a lot, but that's the space where I am right now. It's in a space of evolution and growth, but the importance of working with people in this space. And in working with this person, I didn't get a chance to, I'm doing a podcast with her soon, but I didn't get a chance to ask her specifically because she was on vacation last week, to ask if I could say who she was. But I will say that she's a woman with valued lived experience and recently a new mom. And she mentioned something, and I took it for granted because as a clinical psychologist, whenever we are doing therapy, it's clear, it's part of our protocol, especially as a cognitive behavioral therapist, is that we use always mental health literacy as an introduction. It serves a purpose to create the bond, make the person feel like with whatever we're saying, we're getting, this whole point about, empathy, about, paraphrasing what the person is experiencing, stating facts that research has shown us. That builds empathy. It builds, the therapist is getting what I'm going to. And we quickly go into, okay, now that I've, given you some psychoeducation, now that we've started initiating a clinical and therapeutic relationship, quickly we naturally go into providing concrete skills. What I never realized until I was speaking with this wonderful individual that we're working with and that we've actually hired as a consultant is that essentially we do that as clinician. But in reality, in everyday life, a lot of what we do in mental health, and I guess there's a point to that. We can easily make it widespread. We can easily disseminate it. We can easily publish it, republish it, share. But from a perspective of a person living with a mental health issue or any health issue, is that literacy in and of itself, in the absence of concrete solutions. So what I was doing by default, we just do that. We give mental health literacy and then we proceed with concrete solutions and means. In everyday life, what we're bombarding people who are experiencing health issues is with a lot of information. And we tell them it's normal that you're experiencing these things, but then we kind of just stop there. We don't go to that step of really providing them concrete access to information, tools, strategies to help them. And so in her words, and I put into quotes, is that according to her, mental health literacy in the absence of concrete solutions or means is actually perverse. And when she said that, I'm like, that was in French. I'm like, can you explain to me what you mean by that? And she's like, well, after a while, at the beginning, when you're told it's normal, like the changes that occur during pregnancy, it's normal. Everybody experiences that. But after a while, and not just specific to mental health, but after a while, what ends up happening is that people say it's normal, but time is passing and I don't feel normal and my life is not coming back to normalcy. And so therefore, then if that's the way it should be, then there must be something wrong with me if it should be getting normal for everyone. And so, and then she said, and that's the perverse effect, is that the intent is good, let's just say, but the outcome is not necessarily beneficial. And it sort of got me really thinking, wow, like we're taking it for granted. We're doing all these things, maybe to even make ourselves as knowledge mobilization experts, as scholars, as clinicians, as the media. But what effect does it have? And it really started to get me thinking about this whole aspect of postpartum. And for the longest time, I've been really working in the perinatal sphere, which is the perinatal is defined by the period during pregnancy, which is the title of today's talk, up to 12 months postpartum. But postpartum is much more than just 12 months postpartum. And if any of you here are mothers, or if one day you'll get to experience it, is that once you go back to work after giving birth, your life is not like it was before. It's sort of assumed like, you don't have a 1-year-old or an 8-month-old when you go back to work. But I think that's the whole point here, is that life changes, and it changes in many ways. So this is like a very, I had my RA help me with some of the graphics today and putting together some of the slides. But essentially, what I want you to retain today is not going to be an extensive talk like neurobiological and all that, but I wanted to sort of at least present what goes on, because a lot of the time postpartum, if you're on Instagram or you've seen any ads or what have you, the picture that we present is that, we basically go back to how things were. And so there's what the eye sees, but there's also what we don't see inside of our body. And there's major changes that occur as a result of this. So on one hand, I wanted to just, again, here, this is, it seems like a sort of a very busy slide. But what I just want you to remember, or at least what my reflection now is, that a lot of the times when we were, and as I, even before being a mom, I'm a mom of 2 now, but before being a mom and being sitting in a neuroscience class, and we've often been presented with the neurological, sort of the brain structural, the anatomical changes that occur. And it's often presented, whatever happens in the woman's brain as a result of pregnancy is actually very good. It's good because it prepares the mother for more nurturing behavior. It prepares her to actually, take her focus away from herself, block out all external stimuli, and really turn almost like an attunement towards the child. And it's presented as, and all this is true, it's presented as an evolutionary basis. On the basis of evolution, all these neuroanatomical changes are occurring to really benefit the survival of the child. And so I'm not saying today that that's not what's happening, and I'm not disputing that. It is true, it's good. But what I'm trying to get us to think about is, by having that perspective about, here are the neurological changes that are happening. They're very dynamic throughout, pregnancy. There's sort of a depletion of certain, brain structures, like the gray matter. And then there's sort of like postpartum, things start to replenish, to increase again. So it's a very dynamic process. But I think what we need to focus on is that, yes, these things are happening to the benefit of the child, but what happens to the woman once these changes are in place? What focus is placed on her health? And so that goes into the notion of, it's almost like undermining the woman's health on the basis that, well, you're undergoing these changes, but they're really they're really for your baby. And again, like, this is coming from a position, just to share a little bit, I was raised by a very traditional mom, where these are the things that I also endorse. Like, these things are normal, they're happening, and they're good. And I'm not saying they're not, but I'm just saying, at least I'm not saying, but I'm getting us to think, could it be by focusing that all these changes that are happening, because they're for the benefit of the child, what part of that perhaps undermines the woman's health, the woman's well-being? And this, I didn't put a slide on this, but coming from, writing a CIHR grant last week, where, we're really working on our theoretical framework for why we're positing that the woman in our case, because our sample size is 99%, people identifying as women. So I'm using that term in that sense. But why is it that, on what basis can we say that we need to promote women's health for child development? And I'll address that in a couple of slides. It's coming from a very psychosocial model that's, if you're in medicine, you probably will not be very familiar with. But Belsky's model, which is a kind of a psychosocial model, posited, even though it was a psychosocial model, that essentially the best predictor of child outcome was parental psychological well-being. And so therefore, on this basis, if we're wanting to promote child health, we need to also ensure that, parents, in this case, the maternal health, is taken care of. So it's from that perspective that I'm coming at. We're focusing on the fact that it's helping our child, but at the basis of this, in order for the child to be well, and we know this from studies on, maltreatment, abusive, upbringings, that, it affects the capacity of the mother to be attuned, to be nurturing. So in a sense, by not focusing on the mother's health, maybe prenatally or perinatally, we're also by default impacting the child. But by focusing solely on the child, we're also undermining the woman's health. Are you still with me? It'll make sense at some point, I assure you. So beyond the neurological, and this is just basically, we chose thank you for the feedback there. So we chose a nice systematic review that basically provided a sound basis. So it's not just one study that revealed these changes that are happening at the neurological level. But, so you'll have the reference there, the slides will be provided. But essentially, we know that these changes are occurring, and there's some of you here that are working in that sphere, and you know that this to be true. What I want to also focus on is that not just, like I was saying before, is the pathways. It's not just what's happening neurologically, but it's like, as I was saying before, these neurological even structural and anatomical changes are leading to changes also in behavior via different pathways. And so one of the things that I kind of added it here is that, the parenting experience is that one. We have the typical medical model, like, if we look at it from a perspective of hormonal, endocrine, certain, the structural changes in the brain, some of them having to do with, for example, even, the HPA axis, how, how, and that will affect also, I'll get into that in a second, but that will also have implications on, for example, postpartum mental health conditions that I'll get to in a second. But, one of the things that we need to focus on here is that, these changes in the brain are leading to changes in other aspects of the body, different pathways. One of them, which we're interested in finding out more about, is the parenting experience. Is that essentially, again, I was talking about it before, is that by these changes in the brain happening, it is forcing, or it is initiating the process by which mothers, could also say parents to a certain extent, can become more attuned to the baby's cries, for example, the baby's cues. And again, as I was saying before, that has implications for the baby's survival. So we do recognize that. One of the things as well that I'm dealing with as a clinician, working with perinatal or pregnancy, issues, but also more generally, just globally, is this idea, we're presenting, people or women that have experienced pregnancy, and it seems, like this is how we should be feeling. So my brain is attuned, all these changes are happening at the neurological level, all this endocrine or these hormonal changes are occurring, and, I'm dealing well with this, and it's making me very connected with my baby. But the reality is that, I think for many women, and speaking with people with lived experience, is that some of those images are not actually representing their experience of transition into parenthood. So this is one of the aspects that we're studying, and why I'm presenting it now, is that a lot of those, what I was talking before, like we could say the sort of neurological changes, it's been very well shown that it can also lead to, or different pathways lead to, psychological changes as well. So they're all interconnected. And in this case, one of the things that, I think we're hearing more and more about, if you're in this sphere, certainly you see that things are improving, but it's still, to a certain extent, not discussed really in the aspect of, so we know a lot about postpartum depression, but we don't know, for example, it's often thought about it being fluctuating, or, maybe it wasn't present during pregnancy. So what we're finding with some of the research that we've done is that actually, in terms of lability, so in terms of dynamics or how things are changing, a lot of the women that are presenting with postpartum depression, and sometimes that get help very late, in essence, if you were to have gone back and used some of the designs that we have, and we can talk about that later in terms of research design as well. I gave, like, what's a cohort design, or what's a prospective longitudinal study. But essentially, it's a study that enables us to, really follow the same people over time, and sometimes follow them. In most cases, what we hope is follow them before they're actually presenting with any health issues or mental health issues, so that we can better isolate, the influence of certain key predictors or factors or things that will basically lead or cause some of these conditions in the aftermath. And so therefore that enables us to make these predictive models. But what we do know is that a lot of the women that are presenting with postpartum depression were women that were already either presenting with a susceptibility to anxiety or depression prior to pregnancy, or even during pregnancy. But certainly we know that these prevalence, now we're saying 1 to 4. And I think before COVID, we certainly had more 1 to 5, so 20% of women. Now we're talking more about, 25% of individuals identifying as women. But the issue that I want to present here is that, the reality is for a lot of people, transition to parenthood is not that all that happy. Not to say that it's all negative, but certainly if you ask them to, come up with an image of what their experience of parenthood is, it would certainly not be the previous one. It would be one that's probably more smeared or tinted with like episodes of challenges. And so that brings us into the pregnancy-related change, which is psychological. And so again, I think what we want to, and I kind of addressed this kind of model of biopsychosocial before, but, like Belsky's model talks about, it doesn't talk about necessarily the pathways, but he certainly talks about the outcome, which is because of all these changes that occur in women, but also some of them in men, but the focus is right now on maternal well-being right now, is that essentially it will lead to changes in the psychological well-being of individuals, and psychological imbalance or psychological distress can have an impact on the child. So what we do know, and I recently got the opportunity to work at the INSERM, which is one of the main institutes of health and epidemiology in France. And I got an opportunity to work with a data set over there. And what we were interested in is kind of looking at maternal mental health. In that case, it wasn't a perfect design, but we were able to actually look at maternal mental health 2 months postpartum and look at longer term child outcomes. So in my case, I looked at basically child cognition varying between at 1, 3, and 5 years of age. So it was interesting because I've been reporting on these studies for a couple of years, but now I actually got to conduct a study myself, and what we were able to see is that essentially children of mothers that were reporting sometimes not necessarily just chronic levels. So if you're familiar with some of the anxiety and depression scales, you can have mild, moderate, and severe. And in most cases, essentially, we're able to draw trajectories where the minute for sure, if mothers were presenting with mild levels of anxiety, perhaps the child presented with a lower incidence. But certainly, if you looked at it from a perspective of having or reporting no symptoms of anxiety or depression in pregnancy versus the report of being able to assess some level of distress during pregnancy and immediate postpartum, essentially was related to the greater incidence of child cognitive deficits. And I should say, I guess in this case, cognitive delays or important cognitive delays. So we actually looked at intellectual disability in this case. So we do know that these neurological changes don't necessarily always lead to just greater attunement, that some of these neurological changes might lead to chemical imbalances, which can also be associated with mental health issues during pregnancy that can have basically implications on the mother's health postpartum, but also child outcomes, in this case, longer term. And though we haven't looked at that specifically, research does show that these deficits in children, or these vulnerabilities in children, do last not only in early infancy and childhood, but also lead into adolescence and adulthood. So there's a life course perspective on the implications of maternal mental health during pregnancy. So I guess, I'm just mentioning a few things here about, sleep. And that was also one of the elements that, with the Montreal Antenatal Well-Being Study, and being part of now a new consortium that was just funded last year on sleep. There is not just sleep in pregnancy, but there's one aspect, or I would say one of the 3 axes of this consortium will be looking at the quality of parental sleep. So not just maternal, but parental sleep and child sleep. And I have one of my PhD student right now starting to analyze some of the data in the Montreal Antenatal Well-Being Study to be able to see what are we observing, can replicate some of the data that are obtained from other, for example, studies, longitudinal studies across Canada, like APRIN is one famous one of them. There's also Pregnancy During the Pandemic, that's led by Leanne Tomford Madsen at UBC, actually. So we're trying to really sort of look as well, can we replicate these same exact findings in our cohort study? But essentially what we do know is that, I was just mentioning before that as part of the article that I'm currently, or the manuscript that I'm currently working on with the data from France, is that essentially one of the highest predictor of cognitive functioning is language development. And certainly that has been found in the literature. And so I'm talking about here social emotional behaviors as well. And though I haven't looked specifically at social emotional behaviors in the study that I conducted, a colleague did, and similar findings are being reported, which is again replicating what is commonly found in other large data sets. For example, we have ALSPAC that is in the UK, and if you're familiar with those. So essentially we're finding at the Canadian level what others are finding across the world with regards to psychological distress during pregnancy. And what I do want to mention quickly here is that I sort of alluded to that when I was mentioning, maybe it wasn't clear, it was clear in my mind, but I'm going to rephrase it in case it wasn't. But I think as a clinician, what's important to mention is that it doesn't just need to be chronic level of maternal distress, is that what we're finding even amongst community samples where it's not chronic, it is not a clinical sample, that just, I'm saying just, but mild levels of psychological distress is sufficient to sometimes cause cognitive delays in children as well. So that again points to the importance of not neglecting treatment of these conditions during pregnancy. And then I think what's also really critically important is that this is all in, I'm really sort of a holistic, I'm not a holistic in the sense of, well, I won't make any judgment, but holistic in the sense the whole person. So for me, I'm really a mind body individual. So I guess my role also as a scientist at the Research Institute of the MUHC is that more and more I'm seeing amongst my colleagues that are, physicians studying cardiovascular issues, studying, for example, endometriosis in terms of women's health. More and more, I'm being solicited to sort of bring in, here is our data we're analyzing, where we looked at, for example, anxiety. Can you sort of tell us what you see in terms of whole body and mind interplay between the sort of expression of symptoms? For example, we know that individuals that are higher in anxiety tend to basically feel more chronic pain, or at least be more attuned to chronic pain, and therefore that would have implications not just on symptomology in terms of endometriosis in this case, but also in the treatment. People that tend to be anxious are some that are less responsive to treatment or interventions, medical interventions. So therefore here there's like an incentive, to basically be able to treat perhaps some mental health aspects or some mental health symptomology, while we're also basically maybe medically treating some physiological conditions. And so there's more and more, I'm seeing it in my circle, that the recognition of really taking this holistic mind-body approach to treating very biological functions, or basically sometimes even treating, treatment-resistant individuals by sort of focusing or zoning in on the psychological aspect. But what we see here is that, for me, when I see this slide, it's like there's so many aspects of women's health that are actually being changed, that are being altered. Some of them are regained, some of them are basically never really recovered fully. And so the question to me that I started asking myself is that, we're really focused on trying to get more recognition of the need to screen and to detect the presence of mental health issues prior to pregnancy or during pregnancy. But then I started thinking, what if we were to maybe miss the bigger picture? What if we were to also think about, or to bring about that, because not just the psychological aspect, but because of all the changes that are occurring in women as a result of pregnancy, are we missing the boat to actually sort of also prioritize the importance of postpartum? And so I started to look into, what's being done in terms of postpartum care, because again, I will tell you that this was inspired by the consultant that we have, that we're working with. And she was like, I'm realizing more and more that there are resources, there are plans. Maybe Canada is still lacking and we're behind, and we're working on that. We don't yet have national guidelines. But that's when I started thinking, maybe we're lacking because maybe we need to sort of take a different approach to providing a rationale as to why we should be screening for conditions prior to or during pregnancy. Maybe if we were to also include not just the psychological aspect, but what are the family conditions that maybe we need to take into consideration, and how do we, sort of factor that sort of prenatal health assessment into what could potentially present as problems postnatally. Maybe that can then bring greater recognition to the perinatal sphere in terms of mental health, right? If we were to look at it from a full body, a whole mind and body perspective. But when I was looking, for example, at the World Health Organization, I'm going to have to start wrapping up soon, but, I just thought to myself again with this analogy of what I was starting with, where sort of said, it's okay to it's almost as if we're saying it's okay if your mind and body are changing that much, because ultimately, you'll be a parent and you'll be a mom, and it'll be for the benefit of your child. But again, if we take this basis of Belsky's model, like, looking after our own well-being is actually caring for our baby. It's actually caring for our offspring. It's offering our offspring, or at least investing in our offspring's well-being as well. So when I was looking at this, I'm like, look at all the elements that are related to postpartum care that are baby focused, but only one of them is maternal health. And so when I went back to the Canadian government of Canada, in terms of the guide to postpartum healthcare, most of it, if you look at it again, it's taking care of yourself, but it's kind of like not really, talk about a little bit about the changes after birth, but they're mainly about, I will tell you about sexual and reproductive, the perineal. So basically what's happening to, maybe specific parts of your body, but not necessarily what's happening to your heart, what's happening to your mind, or your brain, what's happening to your, inflammatory system, how these are all interconnected, like I mentioned before. So there's not really any mention of that. And then I also went to see what's being done, for example, in other perspective in other countries. And we have here, for example, this is not a recent article. This is published in 2018. And they're basically here providing what would be the optimal postpartum follow-up. And if you've been a parent, or you have maybe siblings, or you remember yourself, the child care follow-up is very extensive because of the vaccination. So children are practically seen every 6 to 8 weeks, sometimes even even more frequently at the beginning. But this is what the maternal care should be like, according to this task force. And if you've been a mom, that it doesn't look like this at all. You are lucky if you're getting one postpartum visit. And as I mentioned before, most of the postpartum visit focuses primarily on, sort of the postnatal experience. If you had any complications at delivery, sort of elements of, pain related to delivery, but not necessarily questions about, more long-term, what it could be related to. So again, this is just to highlight basically the World Health Organization is giving more or less the same recommendations. But again, like no one's really questioning whether this is actually happening. And I will tell you, it is not happening. And so I looked at other articles, for example, this one here, which had a really interesting perspective, because it essentially was mentioning that, and again, what we found in some of the studies that we're doing perinatally, but what they were basically showing that, every year in the US, there's about like 4 million births. 85% of women will receive prenatal care. So it will resolves itself. I think it's coming back. But then the postpartum care was for most people was am I frozen, by the way?
You're frozen, but we can hear you.
Yes. Okay. I'm trying to see if I can maybe just close my camera and then turn it back on. That usually helps. There we go. I think I'm back.
Yes.
But yes, so back to the slide here. So essentially, most women report having access to prenatal care. And if they don't, it's usually because they choose, or they choose not to accept it. But this article specifically here, based in the US, was highlighting that postpartum care is actually often overlooked, and certainly does not look like some of the recommendations that were made. And the kind of grid that I showed you before was actually US recommendations. So that got me thinking about, what's happening across the world. And essentially, we're seeing here that, you know, there's a plethora of conditions beyond just, women's sexual and reproductive health issues that occur postpartum. As a clinical psychologist, I will tell you, whenever we see fatigue or chronic fatigue, it's often an indication of something more than just fatigue. It's not just the fatigue of being parenting and, you're having more tasks. It's something that could be related to, for example, the mind and that body connection. But essentially, we're looking at it from a perspective of, let's say, if we're looking perinatally post 12 months, one of the prevalence here was showing that actually even post 1 year, the fatigue, the sort of like the mental health precarity was still very much present, and yet remained untreated. So I've already mentioned this. I've mentioned that, health conditions not only influence mothers' health, but also affect children's health. And this article here that I'm citing was actually, this is in 2002, and I did it on purpose. I usually always like to have very recent citations, but the reason why I brought it here is because we knew that then from a study that was conducted in the US that essentially poor maternal health was related to poor child outcome. And the question I have is, like, let's say 20 years later, have we made that much progress in that sphere? And so I'm not going to answer the question, but I'm going to get us to think about it. Some other work that we've done in our group here, and I'm going to accelerate because I knew I had till about 45-50 to wrap up. But essentially, we've been able to develop a tool that we've essentially adapted to the Canadian context from researchers that have basically developed that in the UK. And so we're able to calculate that essentially it is true that the costs associated to perinatal mental health or maternal mental health issues during pregnancy actually represent about 30% of the cost. And essentially postpartum, 70% of the costs are associated to, for example, health conditions, mental health conditions related to the child. So, and this is what the article stated here, is that it's not surprising the extent and content of postpartum healthcare have been critiqued and are too limited to meet the health needs of women. And so I guess the issue that I wanted to bring here is that essentially, what can we do as, either clinicians, as researchers, as a cluster, a collective of minds that think alike and that do think that women's health issues are important. Is there a way to sort of leverage this postpartum aspect, post-pregnancy, and all the physiological changes, going from the neurological changes all the way to the biological and more basic core organs, like in terms of the cardiovascular and the inflammatory system? What can we perhaps do to improve, make sure that, just as much as we prioritize, the follow-up of the child postnatally, what could we do? What could be done to maybe sensitize our decision makers or even the clinicians themselves? Because I'm not getting into this right now, but one of the big argument here is that the reason why it's such a last therapeutic orphan, the pregnant woman, is because essentially it would require time. It would require time and it would require resources in order for that to be made possible, right? So this is just like a little graph that I also picked up from that study, which showed that essentially you have here 3.4% of women 7 weeks. So we were saying that usually you have a visit that's about 6 to 8 weeks postpartum, where there's a potential for maybe a health assessment to be conducted by healthcare professionals to women. But here this study was reporting that essentially less than 5% of women were actually reporting having had that visit. So we see here that, like there's still, the key is, like, if they're not seen early and they're seen later, but perhaps, the day 2 or the first week of postpartum, we're so overwhelmed with things related to this transition to parenthood that we're not really focusing as women on what's going on. So maybe the first week is where most of the assessments or the healthcare visits are taking place, but it's maybe not when the woman is most attuned to what's happening in terms of her own health. And if you're looking at it from a perspective of like say 6 weeks later, maybe when things have, and I would argue that things have subsided, but we see that with time, it basically, the prevalence of the women being able to be assessed goes down. So we do know that from the research, at least from our US counterparts, that that's what's taking place. So I guess that's bringing us to the element that it's not being done. So just to say, and I'll just skip these slides because it basically says the same thing. I just want to take a few minutes to get to what we've done about it, and what we've tried to do with our study is essentially, we figured that implementing a screening and referral protocol would be quite difficult in the way that it needs to be implemented. So I kind of went fast through these slides, but essentially what it recommended is that you need to have at least not just something where we're quickly asking you how things are going. There needs to be almost like a little dialogue set in place where you're basically sort of having the time to have the person warm up to you and be able to maybe share certain things that are going on, especially if you're assessing for mental health issues. So for that to happen, you need to have more than a 2-minute visit with a physician, right? So you need to have perhaps at a minimum a 12 to 15 minutes discussion with your physician. And so we figured, and when we looked at the models, and I went quickly through the Australian guidelines, but what's particular about the Australian and the UK guidelines when it comes to pre and postpartum care is that a lot of the pregnancy care is offered by midwifery, midwifery. So essentially that the care, the dialogue, the 10 to 15 minute dialogue or exchange that I was talking about is already embedded in the pre-postnatal care, which in some areas like the US and Canada, we don't necessarily have. And so we basically decided in terms of feasibility that I'm going to focus on this phase of our study, where we figured we were going to test a protocol by which we could, with midwives, train them to be better at picking up on some of these mental health issues, because a lot of their work focuses primarily on, issues of reproductive delivery complications and these aspects. They're already trained for that, but maybe less for not maybe, we know now, less for the mental health aspect. So we just recently got a third site. I think we'll be close to 5 sites now, but I'll just skip that quickly and go quickly to our screening and referral. So essentially, we are currently testing a protocol with midwives working in the medical space, our feasibility of implementing a screening and referral. And essentially here, what we're trying to do is we're trying to see not only in terms of mental health, how it's going to basically benefit the referral to more appropriate resources, but we want to also follow up the women and see more longer term in terms of health, what that will do. Now, we can talk about it more during the question period. Evidently, for this to really work out well, we need large data sets for that to happen. And so recently, we've been working with another study at the MUHC, the McGill University Health Centre, where we will be connecting some of our practices, because what we're seeing so far is that it is improving the referral, and it is improving the the referral to more adaptive or appropriate resources. And we're thinking that long term, when we follow these women and their children, that we estimate that it's also going to be related to better health outcome. And so with MAWS alone, we didn't have the infrastructure to do that. But right now, we're basically going to be connecting with a project that's called Delivering Healthy Babies. And that's widespread across the hospital, and is looking at multiple factors of women's health, including most of them, the cardiovascular aspects, and even at the molecular level. So we'll be able to basically, hopefully, develop sort of a data set, a large data set, even with biobank, where we'll be able to long-term assess and look at these outcomes in terms of child outcome, but primarily women's health outcomes. And so this is sort of like our screening referral study that we have now. And so part of the protocol calls for training, offering an extensive, it's a few-day training to the midwives on how to better detect, how to better screen, how to better connect, how to create that alliance with the people that they're servicing, as I was mentioning earlier. And what we're seeing is that essentially not only are clients, patients reporting feeling better supported throughout their prenatal care and postnatal care follow-up. And in this case, they do have the 6 to 8 weeks follow-up, but the midwives are also reporting that they're actually feeling much more competent, tooled, equipped, outillés, like we say in French. They're feeling better equipped to be able to deal with the presenting issues related to mental health than they were in the past. So I'll just maybe skip this because of time, but we're basically hoping that implementing this trauma-informed care, in this case, it's really sort of based on mental health, but we see it as possibly having implications as well for mothers and women's postpartum health long-term. So we feel, again, I want to be cautious because, again, I am of the mind that, by improving the woman's health, we'll be improving the outcome of the child, but also of the family. But really with the woman's health at the heart of this whole project. And, we're hoping to be able eventually to pilot this project across Canada. This was not the CIHR that we were submitting this year. But we are hopeful that perhaps, with the foundation support that we've received now, that maybe eventually we can implement this not only with midwives across Canada, but we'd also like to pilot. There's discussion now of piloting that with first line, so with physicians in the medical system per se. But, again, it will require some time. So I will stop here in an effort of time, and we can address more specific questions during the question period. But we do have a model that we have developed that we think could be suitable for implementation. But then again, this is again very experimental and in early phases. But I think the idea is to really see, how can we maybe improve screening of mental health during the perinatal phase and get actual guidelines established by maybe taking a perspective of what are we doing postnatally, and not only from a perspective like the mental health itself, but also what other complications is it causing in women's health, more life course into the more even the geriatric period. So how can we basically merge these efforts together to maybe just promote women's health more globally? And then I'll just thank a few of our partners later on and thank my team as well. But, we'll stop here and see if we can take some questions at this stage.
You can thank your partners, but I will encourage people to show their little emojis. And thank you very much for the fantastic talk, Dr. Montreuil.
Very good.
Not too bad.
Yes.
There you go. Good. That's
just
great.
There, so I can make sure that we can cite this later on that we've mentioned that. What makes I really want to thank the Chamandi Foundation, because they've really been amazing in supporting a lot of our more sort of novel projects. And so therefore, we can then collect some pilot data and then apply for other larger grants with their support.
Yeah, that maybe I'll come back to that in just a second. But I thought there were so many really interesting pieces that you brought up in your talk. If people have questions, I should also say, please feel free to unmute yourself, put your hand up.
Yes, that would be lovely if some of you could exchange.
And or put it in the chat. Also,
Yes.
right after this, there'll be a session for with the cluster for trainees. So any of you trainees, please
Yes,
stick around, and
I'll be there.
Dr. Montreuil will talk to you about her sort of trajectory. Yeah, I thought it was really interesting. We did a little search ages ago where we looked at, articles during pregnancy versus postpartum and books and things like that. Of course, there's, what to expect when you're expecting, and that's a very
Mm.
big popular book. But the what to expect postpartum is about the child. I mean, there's like two
Yeah.
chapters, I think, on the birthing person, but other than that, that's pretty much it. And it turns out, so I tweeted parts of your talk, but as you allude to, it's a barometer. A lot of the physiological changes, including mental health changes, are perhaps a barometer for our health later on. And
Mhm.
um, and so I do think that's a really important part that's neglected. And I guess one of the questions I had was, first of all, it sounds a lot like, in some ways, the Summit trial, which I'm sure you're probably familiar with.
Mhm.
But also I'm wondering, like, in terms of the midwifery part, in terms of your, I think it's Montreal Antenatal Well-Being, are you also asking about more physical health
Mhm.
as well? And because that, as you pointed out, that can also influence mental health, of course, as well.
Yeah. Yeah. So we are collecting information on that. So obviously it's all self-reported at the moment. We are working with most of the participants. We have about like close to 1,200. They have agreed to allow us to connect with their electronic medical records. So we're at the point of doing that now. But again, like, we're aware that even within the MAWS, it'll just be kind of like a snippet of what
Yeah.
we would need in terms of data collection to really be able to make some strong claims, right? Hence the importance of, for example, working with some of the partners that we have now at the hospital, in hopefully implementing a sort of screening and sort of like data, like medical data tracking long term, to be able to make it widespread, but also make it that, over kind of a life course. There's other initiatives, like for example, this week there will be with two major institutions in Montreal, one francophone, one anglophone. There's a lot of push toward, again, collaborating on these types of projects where, like we're looking for international collaboration, we're looking for national collaborations, but sometimes we're not even collaborating within our own city, right, on these types of projects. So we're seeing a steer in that direction, anyways, in our institution. So we are actively looking for that, but we're aware that MAWS is only going to be sort of like a platform to launch hopefully larger projects, but it would need to be institutional, like at the level of the institution, as part of the basic level of care and tracking of medical evolution, for that to really have an impact, I think.
It's just so fascinating to me because I kind of feel like this is a microcosm, whatever I'm trying to say.
Yeah.
In terms of, does seem to be this undervalue of women's health just in general.
Mm-hmm.
Undervalued, understudied, underfunded. And even for pregnancy, we see a lot of attention placed on the, woman, birthing parent during pregnancy, but then it
Yep.
totally shifts. And
Yep.
so if anything, it's all towards the child, as you mentioned. And
Yep.
even the fact, having given birth twice, like 6 weeks, you're barely kind of feeling like you're human again. So
Yeah.
I mean, obviously we need more attention, even prolonged from that six week period.
And that's a fact. I think realistically we can all have this discussion, and it seems to make sense. And that's why, like I said, like, this dialogue was going on like 20 years ago.
I know, and
And
it's still
for
not.
example, why are we still there? And that's kind of like where, like, I'm thinking to myself, like, what can we do differently, right? Because like that, and that's one of our person with lived experience. Like, she told us, she's like, listen, once I gave birth, it came like a slap in the face. I was not expected or prepared at all for this transition. And then she's like, at the beginning, it's, like my baby has all these periodic appointments, and after a certain time, like I wish someone would have just asked me, how are you doing? I would have wanted to be selfishly a bit more about me because I wasn't doing well. And so I think, you know, and the literature seems to point to that. Like, it's not just a person with lived experience. The literature pretty much worldwide points to this, that there is no really clear postpartum guidelines. And I think, you know, I think we need to have that. I mean, that's what I'm debating. This is what I'm questioning. Maybe we need to not talk or just focus solely on the perinatal, but maybe we need to also tie with the fact that whatever happens perinatally also has implication on the postnatal. And what are we doing to better support women's health so that she can actually be a better, in that case, parent? But I think if we start at valuing women's health there, maybe that can extend to all women's health as well. I don't know, right? Because that's pretty unique to the experience of people that are women or identifying, you know, or you know, or birthing people as well, right?
Just one question from in the chat that I think we're out of time, but hopefully it's easy question, and that is endometriosis. So do moms with endometriosis have a higher level of anxiety? Does that seem to bear out in the literature?
So I don't know specifically about pregnancy. I've been involved. I'm involved with a team studying that endometriosis, you know, like outside of pregnancy, if I could say. But we do know that essentially a greater incident. So basically, when you look at different presentations, women with endometriosis complications tend to also present with higher levels of anxiety. So, you know, and again, we just submitted another publication for consideration over the weekend, and that one was looking at other, you know, whenever you're looking at comorbidity, so endometriosis and let's say another condition, and then there's usually always a sort of an underlying transdiagnostic factor, which is anxiety. So those studies are you know, for example, we can say that the results are quite robust because we're looking at, you know, a data set of 9 million people, but we're not looking at the mechanisms by which these are working, the interplay between these variables. We're just saying the incidence of women with endometriosis complication it presents greater level or greater incidence of anxiety. But definitely, and that seems to play also in the presentation or manifestations of the symptoms associated with the primary condition, which is endometriosis, but also in terms of, you know, response to intervention or typical or traditional medical treatment. So I guess one of our conclusion is, you know, is that we should also screen for anxiety, and there's ways that we can do that very quickly with the PHQ-9, or, you know, like there's various tools that are very brief, because it's always that, right? It's the brief tools.
It's so fascinating because I just learned at the last conference or second last conference I was at that for PCOS, there's also increased levels of mental health issues. So, you know, all of these women's health, female health disorders also carry with it some increased risk for other disorders. And I really, you know, this is why we do the cluster, because it's really important to shed a light on all of these things. But with that, we are completely out of time. We're 3 minutes over. I'm going to hand it over to Bonnie Lee, who's going to do the trainee. So if you're not a trainee, can I please ask you to leave the room, including me? I'm going to leave the room. So thank you very much for all your time again, and thank you for the great work you're doing. And
thank you, Lisa. Thank you for the opportunity. We'll talk soon. Good luck with your conference that's coming up too.
Thank you. Thank you. Bye.
Bye.